So thank you for joining us for our first LVS Journal Club. So this is going to be a monthly meeting that we will continue. It will be the first Wednesday of every month at 5 p.m. So this will be our first one. So my name is Sam Stewart. I'm a emergency and critical care specialist. So this journal club will be more ACC focused. But we'll be rotating through all of the specialists at LVS. So each month you should get a little bit of different content in terms of what we'll be focusing on. So today will be a little bit more ACC correlated. So the first article that I picked out sounds a little bit boring. It's comparing IV administration of various gastric acid suppressants. The reason I picked it was because I feel like we all tend to have our own personal opinions about which antacids we like to use better. Some use Pepcid, some use pantoprazole. Some people are true believers in famotidine, whereas other people don't think it works at all. So I feel like this was a nice paper that just tried to kind of start looking between and comparing the different options that you have out there to especially for the dogs that we need in the most, which are going to be dogs with ulcerations and GI bleeding. What can we do for those dogs, and which ones we know are going to work the best? And so, essentially, in terms of an introduction on this paper, they talked about how GI bleeding can have some severe sequelae. Obviously, one is going to be anemia. You can see here in this picture on the top right, there's a pretty big nasty ulcer in the stomach here, as you can imagine that. There's a lot of other sequelae like rupture that could also happen with this. But then when it comes to management of this, really the first goal is going to be medical management, which is generally what we always try first, assuming there's no evidence of perforation. And all that medical management comes down to is creating a favorable environment for clot formation. So whatever we can do to promote better blood clotting, because once you can get that clot to form, you can then start getting that healing to hopefully happen after that. And so one of the big aspects to creating that favorable environment is to bring up the pH, or to make the stomach less acidic, because having that really strong acidity will inhibit a lot of the clotting factors and mechanisms that make that blood clot and form over the ulcer. So in terms of human recommendations that we sort of have adapted into vet med, we talk about increasing the gastric pH to greater than 3. And so for a dog, your kind of average gastric pH for a dog is like 1.5 to 2.5. So it's pretty darn low. So trying to get it to at least above 3 for 75% of the day is kind of like your base goal. If you can get it up above a pH of 4 and maintain that for at least 67% of the day, that's even better. And then if you want like truly the optimal environment, because we know the optimal environment that our clotting factors and other hemostatic components would work, we know that would be a pH above 6. So trying to get a pH of the stomach from 1.5 to greater than 6 isn't exactly easy. Not all of these drugs work quite that miraculously to do this, but that is the ideal goal, so we could actually achieve that. And then once hemostasis is actually achieved with these bleeds, there's the highest chance of it rebleeding within the first 72 hours, most often the first 24. But because we know that it's within at least that first 72 hours, it tells us that it highlights the importance of the drugs that we need to bring up that pH and to essentially make it less acidic. We need them to be rapid onset, obviously, because we want to start working as soon as possible. And we want to have that reliable activity for at least 3 days, because we know that's when we're at that highest risk for a rebleed. So in terms of what this study is looking at, they were comparing 3 different drugs. Pantoprazole, one that we may or may not see, I suspect probably a lot of our practices don't have this, but one called esomeprazole, and then famotidine, which we're all probably more familiar with. And so when we talk about pantoprazole, there are studies in humans that show it's more effective than famotidine, and we assume it to be the same in dogs. But really, in terms of these comparative studies, it really hasn't been that much. So it's really hard for us to say for sure. With esomeprazole, there have been studies in humans that showed it does seem to be better than all of the other PPIs. So including pantoprazole, it does seem like esomeprazole is better. And there have been at least 1 or 2 studies done in dogs that show it does increase their pH pretty reliably and pretty well. So there's some evidence to support it would be good for our patients. And then lastly, there's famotidine, which, there really is questionable efficacy. There's been sort of reports all over the board, some saying that works really well, some say that doesn't work at all. So kind of unclear on what we think is the best option with that. However, it does look like slightly higher doses, and even the administration as a CRI seems to work better. So maybe it's not as bad as we tend to think. And so in terms of the objective of this study, they wanted to compare how well each of these suppress gastric acid suppression, and maybe even better than saying gastric acid suppression at it is the pH that is in the esophagus. So essentially where you're going to get your really bad gastric reflux into the esophagus and singe there, and then also within your stomach at those ulcer sites. And so the hypothesis that they had was that they thought esomeprazole was going to be the most superior, followed by famotidine, and then followed by pantoprazole. And the reason they thought famotidine would be in the middle would be because of the fact that they're going to be using a slightly higher dose and as a CRI in this study, which we'll touch on here in just a minute. So in terms of the study, they had 9 healthy beagle dogs. So this is a beagle dog colony at the University of Tennessee in the U.S. They have a beagle colony there. And so they had 9 of their healthy beagles from that colony. And then on the first day of this study, they sedated them and they placed these little pH capsules. Bravo is the name of the company, but they're these really tiny little capsules here. You can see just like the size of the end of a pencil. And what they do is they go in and they implant them here. So this is an esophageal plantation. In the picture they're demonstrating here, but you've got a little device that is holding on to it. You push it down into the esophagus. You have either, X-rays, or if you have fluoroscopy, you can use fluoroscopy. But you can see it grabs a little piece of tissue and then it basically staples itself in there. And then once it's there, it's good to go. And here you can actually see a picture of esophagus with one actually implanted. And then once implanted and activated, it does continuous pH monitoring, and it will create waveforms for you to monitor that pH over time. And so once it was placed and confirmed that the placement was in, they spent that first day giving these dogs Q6 hours, 6-hour injections of just normal saline. And this was for them to get baseline pH measurements. So what was kind of the normal pH for these dogs at those baselines before they had any antacids given to them. And then starting on day 1, they started on gastric suppression regimen, which would either be pantoprazole or esomeprazole at the same dose, 1 mg per kg Q12 hours. Or they would do famotidine, which is also an initial loading dose of 1 mg per kg, but then had a CRI at 8 milligrams per kg per day. And so they would do that, and then each of these dogs stayed on either of these ones, whichever they were started on, for a total of 3 days. And they had that continuous gastric pH monitoring over those 3 days. And they also looked for any adverse events to see if there's anything associated with these. And so they did that for each of these groups. So dog number 1 got into the pantoprazole group, had its 3 days. It then had a 10-day washout period, and it would then start the next one. So each of these dogs did all 3 of these with that 10 days in between. Most of the dogs needed to have their capsules replaced. These things don't stay in forever. They do eventually dislodge and then pass through the GI tract, but they took RADs beforehand before moving into each successive group to make sure that they didn't need to be replaced, or if they did, then they did. So in total, they had 32 capsules placed amongst all of the dogs. Only 15 remained in place for the full 96 hours, so not exactly the greatest kind of reliability with that, and I think it does have some effects on the value of their data, but at least they did have a good amount of data overall. The good news is that there was a mean increase in the pH in all groups, regardless of which drug or which regimen they had. They all had some degree of increase in their pH, which is what we want. In addition to that, that time that pH is increased over 3 and over 4 was also increased in both groups. So again, every group at least was achieving what we wanted it to, whether it was successful or not. I just heard a little beep beep sound that tells me that someone was trying to get into the room. I can't access to let people into the room from this presentation mode. So if anyone that's in the room, I think you can all let people in. There should be a little check mark that lets people in. So if there's people that are requesting to get in, someone just doesn't mind keeping an eye out for me and letting them in. And then, so in addition to these on the results, they found that really between the groups, there were no significant differences between any of these. So they said they all achieved what we wanted them to. However, it does look like esomeprazole and famotidine might be somewhat more effective in those first 2 days. So there might actually be suggestions of things that are better here, but they just couldn't prove it statistically. And really, this is going to come down to the sample size number. They didn't have a lot of dogs. It's hard to sort of prove that this was statistically significant, but looks like there's enough there that says it might be. And so we want to look at the actual data. So this looks like a messy chart, and we'll explain it pretty quickly. It's fairly easy. You have your, day 0, day 1, day 2, day 3. Day 0 was that day where they're just getting saline, no antacids, and then day 1, day 2, and day 3 where they were getting antacids. And so this is looking at the mean pH, so whatever that kind of mean pH between all of the dogs was. And this line in between each of these vertical lines here is going to be that mean. And so all of this cluster of green dots is going to be the pantoprazole, blue is going to be esomeprazole, and red is going to be famotidine. So on day 0, you can see all dogs were pretty much right about the same. If you follow that middle horizontal line between these as the mean, all dogs are about the same. But for then days 1, 2, and 3, you can see that pantoprazole mean is definitely much lower than the esomeprazole and the famotidine mean. And so when that result was talking about the first 2 days seemed to get better results with these two than pantoprazole, this is what they're talking about, because you can see these two are up here, probably around 5.5 or so, whereas the pantoprazole guys are still under 4. And that continues for day 2 and day 3 for that. And then when you look at it in terms of actual percentage of time over the pH of 3 and 4, so greater than pH of 3 here, greater than pH of 4 on the right side, you can see again, day 0, everyone's about the same because there's no drugs being given at that point. But then day 1, you can see there's that big difference. And I actually got the percentages and I put their percentages in here. So you can see that time over pH of 3 for pantoprazole was only 58%, where it was in the 80s for the other two, which is a pretty big difference. Again, did not reach statistical significance, which is likely a result of the number of dogs in the study. But as you can tell, clearly seems like there's something there. And the same goes for pH greater than 4. Again, big difference between that pantoprazole and the esomeprazole and famotidine group. So big enough you would think there would be something there. So with more dogs, it probably would be shown. And now these two charts don't really matter as much, but they're now looking at pH greater than 5 and pH greater than 6, because you've remembered ultimately the goal is to achieve this. But you can see that amount of time, these horizontal lines are much lower than where they were in the other graph. So it's, like I said, it's much harder to get to this point. There's less difference between all the groups, so you can't really make any claims about one being better than the other. So it gets a lot more hazy when you try to get up here. But going back aside for the 3 and 4, you can start seeing that there are some much more obvious dichotomies between those and which ones you'd probably want to lean towards with using. And when it comes to adverse effects, there was a couple dogs that maybe had occasional episodes of vomiting. Whether or not that was truly related to the drug, it's hard to say. Most of those dogs, it was on days 2 or 3. But all of the dogs had a great appetite throughout the study. None of them had any loss of appetite, even the ones that vomited. And between the groups of all of these drugs, there were no difference with these episodes. So it doesn't seem to necessarily be drug-related, in particular to any of these. And so in the discussion, like I said before, there aren't really any validated guidelines in veterinary medicine for what is the goal when we're trying to reduce acid for these ulcerative patients. However, we just kind of adapt to the human guidelines and say that's probably what's going to be good enough for us for now. And so that's going to get that pH greater than 3 for 75% or pH greater than 4 for 67% of the day. Both esomeprazole and famotidine achieved better percentages of time over these pH limits. However, additional studies are needed to really verify that, especially ones with more than just 9 dogs, still single-digit number of dogs. But like I said, those numbers that we saw are pretty suggestive that there is something, some superiority here, being the esomeprazole followed by the famotidine. But if we really want to say that definitively, we need additional studies. And then, like I said, there really wasn't any significant difference between these groups, which is why we would need the additional studies. Now, there have been previous studies in both humans and I believe in vet patients. Don't quote me on the latter, but I believe in the dogs there have been that have shown esomeprazole is effective at lower doses. So rather than 1 mg per kg, maybe 0.5 mg per kg. And so that might be, again, trying to save costs, depending on what we can get for these. This might be a way to actually make this less expensive than some of our other antacid options. And then the other question is, can you give this as a CRI, maybe have it be even more effective, kind of like how it seems like famotidine is better as a CRI than intermittent injections. But there have been previous studies done in both humans and vet patients that have shown that PPIs given as CRIs really is no different than intermittent injections. So most people just stick with intermittent injections because it's easier, and there's less sort of hands-on time of having to monitor and deal with that. So it's easier in terms of nursing care. And then ultimately, esomeprazole seems to be the best choice for dogs with GI hemorrhage based on this and some previous studies. It's intermittent injections. It's not a CRI, so there is technically lower costs associated when you're not having to do a CRI. There's lower concern for drug incompatibility. So this doesn't really tend to react with a lot of other drugs. It doesn't really crystallize, what's in contact with other drugs. So you can have it in a shared catheter. And then there are other drugs that you can see diminished effects. So less acid suppression with time. And specifically, this has been shown with famotidine. And that is particular with the oral formulation. So we don't know if this happens with the IV formulation, but we know with oral famotidine, this is a chart that I pulled out of the paper that the current paper was referencing, where we can see these were dogs that were getting famotidine, days 1, day 2, then it skips to day 12 and 13. But you can see that initial effect of the famotidine brought these dogs' acid up to a mean of 4.9, which from 1.5 to 2 is pretty good. But by day 13, that effect was pretty diminished, and it was bringing it up only to a little bit over 3. So again, we don't know if this happens with the IV formulation, but because it's possible, that's why we believe that esomeprazole is likely the better choice. So there are some limitations with this study. As you saw, there was a variable amount of times those pH capsules actually remained in place, and more than half of them were dislodged before the full time limit of the study was done. So especially on those later days, day 2, day 3, it's a little bit harder to interpret that data because there's not as many patients in those groups. The other thing is to remember is these are all healthy dogs. These pH effects are really good to know for dogs with GI disease because they might respond different to these drugs. So just because we see these really beneficial effects with esomeprazole comparative to the others in this study doesn't necessarily mean that's what's going to happen in a diseased dog. So we do have to be cognizant of that when we are, using this to make choices in our clinical practice. And something that I've said quite a few times throughout this is sample size. 9 dogs is not that many, and that is especially when you have days 2, day 3, where it was even less than 9 dogs. Trying to derive really true statistical significant results out of something like that, it's really hard, and it pretty much is almost impossible. So, like we said, the study definitely shows suggestions or correlations that some of these things might be better than others, but really we need much bigger studies to show that. But I think it's at least enough for us to say, what, I believe I'm going to somewhat alter how I treat these patients based on this, but I acknowledge that we need to see more information for me to, truly have that confidence that this is the right choice. But it was an interesting article overall. Like I said, it at least for me, gave me an introduction to a PPI that I'm not very familiar with, which is this esomeprazole, and it also gave me this idea to start using famotidine as a CRI, where I, rarely would ever have done that before. So I think there were some interesting tidbits to have pulled out of this article. So that's it for that one. We'll move on to the next one. Maybe we can, if we have time at the end, I'll open it up to questions if anyone has any about these, and we'll just kind of go through them all at that same time just to keep a nice flow here. And now the second article that I have is looking at post-operative regurgitation respiratory complications, specifically in brachycephalic dogs. And seeing if there is an improvement with a standardized peri-anesthetic protocol in these postoperative complications. And so as the introduction, brachycephalics, as probably all of us know, don't exactly have very normal upper airway conformations. They have small nostrils, they have an elongated soft palate, they have these redundant pharyngeal folds and really hypoplastic tracheas, clearly just culminations of things that just add up to them not being great at breathing. And what this does is it increases their inspiratory effort, which you can see just by looking at them. But the one thing you don't realize that this does is it increases the amount of force that they have to inhale when they're breathing, and that creates this really large negative intrathoracic pressure. Now, negative pressure in your chest is how you breathe. That's totally normal. But when you have to use more effort to breathe, you make that much more negative. So that increase in even more negative pressure induces them to problems. And what that does is that pressure can get transmitted to the abdomen. And what that does is it can make you more likely to have vomiting regurgitation. It also can make you more likely to aspirate when you do vomit. And having all of this also can induce inflammation when you're having a higher degree of work for breathing. And that inflammation can make it even harder to breathe and then have respiratory distress that might not necessarily be pneumonia related, but more so upper airway obstructive distress. So overall, lots of issues with these guys. And not only that, but previous studies have shown that up to 97% of brachycephalics have some sort of abnormality on biopsies of their esophagus, stomach, and duodenum. And what that tells us is that if there's that many that have just some degree of abnormality, and again, some of these are just mild inflammation, nothing crazy, but it all tells us that these are dogs that are now doubly at risk for aspiration and vomiting regurgitation, because not only are they going to have breathing changes that are going to increase their intrathoracic pressure, they also have GI abnormalities that are going to make them want to have vomiting regurgitation. So it's kind of like a perfect storm in these guys. And so, there's certain things that we try to do with these patients to reduce these risks of postoperative complications. And so, a big part of it are the peri-anesthetic drugs that we use, and the big one is opioids. We know that opioids reduce lower esophageal tone, so you're going to get more reflux with that. You're also going to get a reduction in the peristalsis. There are anti-peristaltic mechanisms with opioids, morphine and hydro being the two worst ones, which makes sense because they're your pure mu opioids. But we know for a fact that both of these increase vomiting reflux in dogs. Like that's already known. In addition to that, a lot of patients under anesthesia can't protect their airway, and sometimes that even, kind of goes for the dogs that are in the immediate post-extubation point after they're recovering from anesthesia. Some of those dogs are protecting the airways, but it might not be 100%. So those dogs are still at risk for aspirating, and that goes doubly for your brachycephalics because of that increased negative pressure in their chest. And so with the brachycephalics, we know from the previous studies that they have higher incidences of postoperative regurgitation than other breeds. I mean, that's not very surprising. But these guys here at Tufts University saw that and said, that tells us there is a need to make better anesthetic protocols. If we know for a fact that they're doing it more than the other dogs, then maybe we need to tailor what we're doing anesthetic-wise to these guys and do something different, because clearly we're seeing that there's a change here and that we need to do it better. And so in 2013, these guys at Tufts made a standardized protocol aimed at trying to reduce these peri-anesthetic complications. So what their objective and what they're hypothesizing is that they wanted to determine whether the implementation of a protocol like this would actually be successful in reducing these postoperative complications. And they believed, or they hypothesized, that there would be a lower incidence. So in terms of the methods, the standardized plan they had, this is a summary of it here. I'll show you a picture of what the plan looked like a little bit later, but in this Teams group, there is a file that has all of the articles that we're reading or that we're going to be reviewing for each month. I'm going to try to have that updated at least a week or two before each one of these sessions, but in there I also put the actual PDF version of the guidelines that they used, that they still currently use at Tufts. So if anyone wants to have those, it's all summarized here, but if you want the actual original document, it is in there for you. And so essentially what they did with these dogs is they started them all on a standard course of famotidine and metoclopramide, pretty standard doses for what we currently do. And so if these are dogs that have no previous history of, GI issues, no vomiting, no regurgitation, then just give it immediately before their pre-meds, maybe, 5, 10, 15 minutes beforehand, let them take effect, and then give your pre-meds, and then continue on with the rest of anesthesia. But if they're a dog that has a history of GI issues and vomiting regurgitation, then ideally start these at least a week pre-op and really give them a chance to try if there's any underlying flare-ups of GI stuff. Granted, these aren't necessarily going to fix a flare-up of inflammatory bowel disease, but it'll at least make it less reactive, hopefully, when you are undergoing anesthesia. Now, if possible, try to reduce opioid use in these dogs. This study was primarily looking at airway surgery, but this study did allow those dogs to have other procedures and, certain procedures, especially abdominal things. It's kind of hard to really totally cut out opioid use, but, looking at alternatives, a lidocaine CRI or a ketamine CRI in surgery can really significantly reduce how much opioid use that you have to have. And then with that, there's also new products coming out all the time. There's now liposomal infused bupivacaine that you do a splash block as you're closing abdominal incisions, and they've shown that significantly reduces opioid use. There's lots of things that we can do to reduce this. It's all stuff that maybe we're not all super familiar with, but the papers are out there, the research is out there, so definitely a good thing for people to start looking into, because even in non-brachycephalics, trying to just reduce opioid use is a good idea. If it is an airway surgery, so again, this is pretty specific to your brachycephalics, give them a dose of dexamethasone, 0.15 mg per kg, and so this is a 1 mg per kg prednisone equivalent here. But giving this basically immediately prior to surgery. So they're already under anesthesia right before you start cutting, giving them an IV dose of this, because the closer you can give it to the actual time of starting surgery, the better anti-inflammatory properties you're going to get. And then once surgery is over, delaying that extubation until as long as possible, getting that patient as fully alert as you possibly can. That way you know that they have the most protection of their airway, because like we said before, even once they're extubated, if they're still kind of sleepy, they still might not be protecting that airway 100%. Considering giving some of these guys flow by oxygen, because again, they're going to most of these guys are going to have some degree of increased respiratory effort, just regardless of whether or not there's been any complications. And having that flow by can reduce the amount of effort they feel that they need to exert breathing. So therefore, it'll reduce that negative intrathoracic pressure and will reduce the potential of them having regurgitation. And then closely monitoring these guys. So specifically at Tufts, they said these guys all must need to be recovered in an ICU because they have a separate ICU and a step-down ward. And a lot of these dogs are routinely recovered in the step-down ward. And they said, no more of that. They all must be in ICU. And so that was another big change for them. And now this was a retrospective study that they did. So these were anesthesia protocols that they made just physically for the hospital. They gave it a number of years, and now they decided to go back and say, well, let's see if it actually made a difference. And so, like I said, 2013 was the year that they did this. So they looked at the 3 years beforehand and the 3 years after that they had implemented this protocol to see if there was a difference. And, they looked at, signalment. Was there any difference in, breed, age, weight of all these dogs, which, could confound the final results? What were the surgeries these dogs were getting done? And then the stuff that we really care about, post-op regurg, respiratory distress, and pneumonia, what were the rates? And so in terms of this, Group A are the dogs that were pre-protocol. So this was before they enacted all of this, and there was about 40 dogs for that. Group B were all of the later dogs that had the protocol. It was about 44, pretty nice, similar numbers. There were no differences between these groups in terms of the signalment, in terms of previous history of GI problems or pneumonia. The duration of anesthesia of these two groups were under about the same. The dexamethasone use and the overall surgical procedures that were done were pretty much all the same in these. Now, what they found, though, is regardless of which group these dogs were in, post-op regurgitation was higher in dogs that have a previous history of GI problems, which not very surprising, but, just now having physical proof that, it is that, as we would expect, that those dogs would have a higher risk. These next two things are going to seem pretty obvious. More metoclopramide use in Group B and more famotidine use in Group B. Again, that's because that's what the protocol said. So it is nice to see that people were actually adhering to a protocol, 89% and 91%. But even more impressive is just being able to show that not only did these people enact a protocol, people actually made the change, 13% to 89% and 15 to 91. That's a big change. So it's nice to see that not only did they make this protocol, but people actually stuck to it and did it. The other thing that you could see is that they did also notice that there was a decreased use in intra-op and post-op opioid use. Pre-op, there was not a difference because there's just so many pre-med combos that have an opioid, but the other two were reduced. So the Group Bs, again, guys with the protocol in use, were down to 27%, whereas before it was 55%. So that was pretty much cut in half. And pretty much same for your post-op opioid use. It got down to 45%, whereas before it was 88%. So pretty big reductions there. And all dogs in Group B recovered in the ICU, whereas beforehand it was only 78. So again, just confirms that people were actually following the protocol like they wanted. So in terms of the results of the big things that we care about, post-op regurg, aspiration pneumonia, and respiratory distress, you can see there is definitely a big difference between Group A and Group B with that post-op regurg. 35% getting cut down to 9%. That's pretty good. Now, in terms of your p-value, for this to be really significant, it would have been great if we could have seen that be a little bit lower, so it's not quite at the full statistically significant value that we would want to see it in. Again, 40 dogs in each group, retrospective study, not, it's got its biases and its issues. That's probably where this is coming from. Clearly, there's a difference to support that this makes sense to do. And this should tell us that, yes, that's pretty, even if it's not statistically significant, it's pretty darn close. So it tells us that there's evidence that it's working. With the aspiration pneumonia, again, lower percentage, difference of 2 to 5 is, 5 or 5 down to 2 is really not that big. So not surprising that p-value is not close to statistical significance. So it doesn't seem to make a huge difference in the aspiration pneumonia. Again, this retrospective study, they weren't monitoring these dogs closely for aspiration pneumonia. They weren't taking post-operative, regularly scheduled x-rays to look for evidence of pneumonia because some of these dogs maybe were aclinical and resolved it on their own. So it really wasn't a focus of the study very closely. So again, take this for a grain of salt. And then respiratory distress. So these would be like the dogs that more so have the upper airway obstructions from inflammation. A little bit of improvement in here. Again, it's hard to get a statistically significant p-value out of this just because of the study design, but maybe a little bit of something there. And then I just noted here that the first regurgitation episodes in most of these dogs occurred in the first 6 hours after extubation. So if we're doing closer monitoring on these dogs, that's definitely the most critical period to be keeping that eye on them. So for discussions on this paper, the results very clearly support that this use of a peri-anesthetic protocol in brachycephalic dogs, in this study undergoing airway surgery, but in reality, extrapolating this for other surgeries as well, clearly there's some benefit there. The study showed a lower incidence of post-op regurgitation, which to me I think is the biggest, thing to show in the study, and it's beneficial in patients that don't even have clinical signs. So, even in patients that don't have previous gastric or gastrointestinal symptoms like vomiting, regurgitation, they were able to show that the post-op regurg was less in patients regardless if they had that or not. So clearly, you don't need to be showing these clinical signs beforehand to be able to experience the improvement in post-operative complications by doing this protocol. Now, there's been previous studies in both humans and veterinaries that have demonstrated the ability of famotidine to reduce GER, which is gastroesophageal reflux. Kind of like how we talked about just in the previous paper, famotidine CRIs might be a little bit better at it. But to me, I think just getting some famotidine in as opposed to none is going to be better for these guys, as proven just by this study. And then opioids, especially your full muse, which are going to be like your hydro and your morphine. We know they decrease gastric emptying. We know they decrease peristalsis, and therefore are going to increase vomiting, regurg, and gastroesophageal reflux. So really, the ideal thing is to try to reduce the use of these as much as possible, which isn't always possible. But we do know there's improving efficacy of our non-opioid analgesics that are out there. There's other methods that we can use, more local blocks, more non-opioid injectable medications, that liposomal bupivacaine like I talked about before. And so hopefully we'll see our dependence on those opioids get even less with time. And then a big thing with this study that they somewhat kind of mentioned in the side, but I feel like they didn't sort of highlight as much as I would have liked, is that, yes, like they said, the study showed that there was a significant reduction in opioid use in these dogs. However, the opioid use that was reduced was primarily buprenorphine. And as we know, buprenorphine is not a full mu agonist. And so there's really not been many studies that have, or really none as far as I know, that have evaluated buprenorphine's association with gastroesophageal reflux. So when they say there is a reduction in opioid use, again, take it for a grain of salt, because to me, that would have meant a lot if that was hydro and morphine. But when it's buprenorphine, I don't tend to take it for as much value. I mean, it still clearly is a significant result, but it does make me question a little bit more, and that with the reduction in post-op vomiting, regurgitation that they saw, maybe it was more so the metoclopramide and famotidine and less so the opioids. But at the end of the day, the opioids are probably still some degree of a contribution to that improvement. So there should still be that effort to try and decrease them as much as possible. And then lastly, consider these peri-op gastroprotectants. I mean, I kind of already said this. So, but most importantly in those dogs, if anything, the ones that had the previous history of regurg or GI symptoms. Just a little bit on metoclopramide, because they did take a little bit of time to talk about it in the discussion. So I just wanted to give it a little bit of time here in my discussion. So we know metoclopramide works by a few different mechanisms to reduce this gastroesophageal reflux. One is that it does actually tighten the lower esophageal sphincter, so just reducing how much can physically reflux into the esophagus. But it also increases the peristalsis of those contractions. So if anything does reflux into the esophagus, that peristalsis can help get that pushed back down, hopefully get it out of the esophagus. Now, there's been a little research done in brachycephalics specifically looking at how effective is metoclopramide in this group of dogs at reducing their reflux and regurgitation. So we presume it would, but there's not been any studies that are just focused on specifically them. There has been one study that looked that was predominantly brachycephalics that showed that higher doses of metoclopramide did seem to work better. So I wrote here what the high dose and low dose were that they used, which I will admit are much higher than what I typically use. So I wouldn't necessarily use these right now in practice. I think they were more so going to show the difference in effects on reflux. So, I think everyone probably has their standard kind of equations that they use. So I would probably stick with what I use and don't go with these. But again, it's proving the point that with our GER right here, gastroesophageal reflux, with nothing was 67%, low dose was brought down to 44%, and high dose was brought down to 33%. So clearly it does seem to be dose responsive, and even when it's not this massively high dose, the kind of lower dose still clearly makes an improvement. So it clearly seems like it has some benefit there. Oh, and clearly I highlighted that. So in continuation of the discussion, post-op regurgitation, like I said before, most of these dogs didn't start until at least 6 hours after extubation. And so it has to kind of bring in the question is, does some of the sedation, as it's wearing off into those later stages, kind of as that's wearing off, is that when they're at the higher risk for it? And that's why there is this delay until it starts. Again, maybe as that sedation is wearing off, is that when they start getting a little bit more stressed because they're more aware that they're in the hospital, they're painful, they're going to get a little bit more worked up. That will then lead to an increased rest rate and rest effort, which could then progress to that increased intrathoracic pressure and everything else that we talked about from there. But is there also intraoperative gastroesophageal reflux while they're still intubated and physically in surgery? We know from previous studies that this happens way more than we think. And having that gastroesophageal reflux in surgery, granted, it might not be happening once you extubate them, but it still happened while they were intubated. And because it happened while they were intubated, that is still gastric acid in your esophagus causing ulceration and irritation, which is going to then decrease peristalsis and increase your chance for postoperative regurgitation. So again, this is what is stressing the importance of those preoperative gastroprotectants, because we know that this happens quite frequently, even in dogs beyond your brachycephalics. But if this is truly, the stress factor of this being a big contributing factor to why these guys, are having this post-op vomiting greater than 6 hours, then that does also, in addition to the recommendations that are already in our protocol, it says maybe they're reducing our hospitalization and reducing the stress, and maybe adding more sedation or whatever we can do to get these dogs out of the hospital sooner would be better. And then, and this is a pretty obvious bullet here, previous studies showing a higher incidence of this reflux with dogs with opioids, which, kind of with everything we've already talked about is not all that surprising. And so this was actually a previous study looking at just that morphine in dogs and the incidence of vomiting and GER in them. And so dogs with no morphine, low dose, high dose, vomiting, and then all cases of GER, you can see both of these categories go up pretty significantly as you get higher in your morphine dose. So obviously there's an association there, which isn't overly surprising. So in this study, there was a pretty low rate of post-op respiratory distress and pneumonia with no differences between the groups, which is great. Historically, rates of pneumonia post-operatively in these groups is 0 to 5%. And as we saw, the group before this protocol was 5%, and the group after the protocol was 2%. So they both are pretty much within what the normal range is anyways. So that would probably be why there wasn't any, majorly statistical significant results out of that. But to me, some of the important take-home points out of this is that with the development of this sort of standardized protocol, is that there's some pretty good benefits that you get out of it, which is that it facilitates the implementation of these new strategies and assures that everyone within the hospital will utilize them. Not only that, but because everyone in the hospital is aware of it, it's increasing that awareness that we need to manage these patients differently, because like we said before, the whole reason Tufts even made this in the first place is they recognized that they were doing the same anesthetic protocols for two different patient populations, and they were getting different results with what was happening post-operatively with complications, which told them they needed to change. And so having that awareness of saying, I recognize that while we're doing the same thing in all these groups, not all patients are going to be the same, and we need to be more thoughtful about the protocols that we're using for each of these. So, whether or not people are, using this all the time, it still made them more aware that things like this are important. And then most importantly, overall, it's improving patient care. We're doing better by our patients. We're helping them have less complications. So that's obviously important. Now, ensuring compliance with something like this is pretty difficult. Things that they did at Tufts, they were very proactive about hospital-wide distribution of this protocol. All services had to be aware of it. They had regular meetings to discuss it. They had instructions about how to implement it beyond just what the protocol itself said, and they pasted it all over the hospital so that way people constantly had to see it, and it was always on people's minds. So if you're in a hospital, you're thinking about implementing something like this, definitely follow the guidelines that they have here, because like you saw, they had some pretty amazing responses to it and getting people to commit to this protocol. Now, there are some limitations. Like I said before, this is a retrospective study. They are making some of these, incidences of post-op regurgitation and vomiting and all these other complications. The people weren't, necessarily looking at these primarily at the time, back in 2012 when they were looking at some of these dogs. So these records might not be the most accurate, and so therefore you have to have some degree of caution when you're interpreting the results. And another thing is they also didn't physically monitor these dogs for gastroesophageal reflux, which we know is a big other component to these dogs having postoperative complications. And we talked about the big ones being, abnormal upper airway, which increases negative intrathoracic pressure, pre-existing GI disease. But actually monitoring for esophageal disease is not something the study did, and that's going to be a big component of these dogs being at risk. Another thing is that not all the dogs in Group B received dexamethasone. And remember, all of these dogs were primarily getting airway surgery and then potentially another surgery after that. But some of the surgeons in this hospital preferred NSAIDs, and therefore they didn't use the dexamethasone. They just used their NSAIDs like they're used to. So when you're looking at that postoperative respiratory distress, not the aspiration pneumonia, but the respiratory distress that might be more upper airway inflammation related, again, you have to interpret those results cautiously because there wasn't a standardized protocol necessarily being used for that part. And then, again, broken record, small sample size. So use this more as an exploratory or an interest driving study and hypothesis generating, but don't make any final decisions off of it. So in conclusions, this data clearly supports an implementation of a standard peri-anesthetic protocol, whether the one that they have designed is truly the bee's knees of the one to use, or if there should be some alterations made to it. But obviously there was an improvement. Obviously it shows you that implementations of things like this are good, so it should be done. And then larger prospective trials, again, prospective, not retrospective, to really show that it works to support it. So that's the end of that paper. The last paper we're going to do is actually one that I just got submitted and approved for publication. It's actually not even in print yet. This is still an electronic publication. And so this is a nonprofit research group that I work with in the US called Ethos Discovery. And we have a pretty big program in hemangiosarcoma. And so we did a big study a couple years ago in hemangiosarcoma, and we have another big one coming up starting actually this month. So this is the first of 5 papers coming out of our first study. And so what I'm going to do is give you a quick review of this one. The first paper out of the 5 is honestly going to be the most boring. It's just the one that's currently published, so it's the one that I'll kind of tell you guys about. And there are some important points to take out of it. It's not all that boring, but I think there's good things to know about this. And then I'm going to go ahead and give you guys a little bit of a review of what our future upcoming papers are going to be in this new study that we're going to do, because I think it's all really important. It's good for you guys to have that awareness. And I think there's some important things that we've learned out of these studies that it's good for you all to know. So in terms of an introduction, hemoperitoneum, I think we're all fairly familiar with, dogs that present with blood in their abdomen. 2 big causes: traumatic, like a dog that got hit by a car or fell out of and fell multiple stories. Then there's your non-traumatic, so these are going to be your spontaneous ones, like a tumor rupture, which is probably the most common reason that we see these dogs. And so most common reason for a non-traumatic spontaneous hemoperitoneum is going to be splenic rupture, and that's going to most often be because of a tumor. And with those tumors, they can be either benign or malignant, with the benign lesions being either nodular lymphoid hyperplasia or hematoma, and our malignant lesions being predominantly hemangiosarcoma, but there are also stromal sarcomas, lymphomas, mast cell tumors, as well as other ones that I didn't list that you can also see in the spleen. Now, previous reports have said that the malignancy, when you have a hemoabdomen and a splenic mass, that's going to be malignant in 68% of the time, with some studies saying it could be up to 96% of the time, which is obviously a massive number to say of those dogs are going to end up having a malignant cancer as the cause of their hemoperitoneum. Now, one thing to keep in mind, though, is that like most studies in veterinary medicine, unfortunately, a lot of these previous studies on hemoperitoneum have been retrospective. And so we've already given you kind of in that last study a couple hints as to why these aren't always going to be the most accurate way to look at these patient populations. You're going to potentially overestimate, poor outcomes. You're going to maybe overestimate or underestimate the occurrence of certain types of tumors. So while these numbers are helpful to help guide us, we have to recognize that, especially like this 96% one, if it seems almost a little bit too dramatic, again, you have to realize that there are these biases in retrospective studies, and that's probably why, again, I wouldn't never tell an owner there's a 96% chance their dog has hemangiosarcoma with the hemoabdomen. So, you got to be cautious about how you interpret some of these numbers. But the big reason for us to do this study is that we had a concern that there was an over-reporting of poor outcomes to owners, and that we felt that there were dogs that are out there that are getting unnecessarily euthanized because they present with hemoabdomen, but maybe had a benign lesion that they would have been totally cured with surgery. So the objective of the surgery was to conduct one of the first, so we didn't do the first prospective study in canine hemiparatinium, but we did do the first nationwide multi-center prospective study. And in prospective studies, it's probably only like the second or third. So there's really been very little prospective stuff done on this in dogs. And really what we wanted to see is what is the prevalence in a prospectively evaluated group of dogs of benign versus malignant, and then what is the perioperative morbidity and mortality, not the long term, just the immediate perioperative in, around the surgical removal of their spleens. And so what we did is we had 10 hospitals. They're all ER and specialty hospitals, no GP, just specialty across the United States. A dog was considered eligible as long as they had hemiparatinium that was secondary to a splenic tumor rupture. They all had full staging performed preoperatively to look for METs. So here's a nice ultrasound of a spleen with a big old tumor on it. But we it had chest rads as well. We did cardiac ultrasounds also, looking for METs in every possible place that we could imagine. All of these dogs were then splenectomized, had their spleen submitted for biopsy, as well as any other lesions that looked suspicious for metastasis. And then we also took additional tissue samples for these other portions of the study, which I'll tell you a little bit more about later. But basically a lot of DNA preservation, RNA preservation types of techniques that we were doing. And then postoperative care, we left that to the discretion of the doctor. We didn't give them any specific instructions on how to do this. We just mostly wanted to see what was the typical postoperative morbidity, mortality as standard of care is done currently in our hospitals. And so of our results, we had a total of 40 dogs that were enrolled. The big interesting thing to me is that we actually had almost 40% benign and just a smidge over 60% malignant. So when you look at that other previous report of the 68 to 96%, this is much lower than a 96% malignancy rate, and it's even lower than the low end of that previous rate of 68. So we have one of the lowest frequencies of the lowest frequency of malignant tumors of any of these other studies. And with us being prospective, we believe that that's a little bit more accurate than what a lot of the retrospectives have said. So this is a pretty important thing for us to know, is that maybe not as many of these dogs are coming in with malignant disease like we thought. Now, we had 2 dogs that were euthanized intraoperatively just because of the severity of metastasis that they had. But overall, we had a 95% survival to discharge, which is great. Most of these dogs were discharged in under 40 hours, which is a great thing to tell an owner that are nervous about admitting their dogs to the hospital. You can say, listen, your dog is going to be out of here in less than 2 days. They have a significant chance they're going to survive surgery and go home. So this would be encourage people, along with those improved numbers, that they should be pursuing surgery. Now, the preoperative ultrasound findings, there are some really interesting things that we had in this, which is that there were 9 dogs in surgery that were found to have liver nodules. We found those liver nodules preoperatively on abdominal ultrasound in 8 of them, which is great. I mean, we only missed it in 1 dog. But the interesting part is that only 3 of them, so only a third of these, ended up being metastatic. And so what that made us think is we use this ultrasound as our preoperative staging in all of these dogs. And if we see these liver nodules, we caution owners that these might be METs, and a lot of owners euthanize for that reason. But what this tells us is there's actually a better chance those are benign than malignant, and people are making euthanasia decisions based off of this finding when there's a higher chance it's benign. So this is really important because we don't want people euthanizing their pet with benign disease under the assumption it's metastatic by something that we now know is more likely not metastatic disease. Now, what was more concerning is that we did have 5 dogs in surgery that had omental metastasis, and that's what this picture is. This isn't from one of our dogs, but this is just a picture of a really nasty omental metastasis of hemangiosarc with all these little nodules all over here. And for the 5 dogs that we had, we did not see this in any of the dogs preoperatively on ultrasound. And as you can tell, these can be small little nodules. This is not easy to find on ultrasound. You can totally see why it's not easy to see. But it's still concerning that we had this many dogs with these omental mets that we didn't know going into surgery. Instead, we were focusing on liver nodules, what it seems like are less important, whereas this is the bigger problem. And then also, interestingly, we had no dogs with cardiac lesions, which we totally expected that we would. So it's interesting that we didn't. We had dogs later in the course of disease when they ultimately died that had cardiac lesions at that time. But at the time of presentation, we had none that had them. And then just some interesting side notes throughout that sort of morbidity period and the postoperative while they were in the hospital. We had just under half the dogs get transfusions. All of these dogs survived to discharge, but they did have longer hospitalizations. So there were some previous studies that have showed lower survival rates in dogs that had transfusions. So ours did better. We didn't have any that died. That longer hospitalization, we don't think this is necessarily related to the transfusions because we didn't have any transfusion reactions in these dogs, but the fact that they needed a transfusion probably indicates that they came in a little bit sicker. So it's not surprising that they probably had a little bit of a longer hospital stay. They also had a median shock index of 1.2. I'll explain what shock index is when we get to the discussion. So for right now, just know that a shock index means if they have shock, as it says in the name. Anything with a score above 0.9 is a diagnosis of shock. So not surprisingly, the majority of these dogs were in shock when they presented. More dogs that were in shock ended up needing a transfusion than the dogs that did not have shock. This didn't reach statistical significance, but again, this is likely sample size related. 40 dogs is a good number, but it's still not quite high enough to really get good statistical significance. But as you can imagine, dogs with shock would probably be more likely needing a transfusion because it's probably their anemia that's contributing to their shock. Whether they presented with shock or not, though, there was no difference in hospitalization times for those two dogs. So it just shows that we're really good at kind of correcting shock and getting all the sequela of that corrected pretty quickly. We also had just under half of our dogs having ventricular arrhythmias. Most of those were VPCs. We didn't really have very many dogs that had ventricular tachycardia, and that's evidenced by that we had no dogs that required antiarrhythmic drugs, which is also surprising for us. We thought there would be. 88% of the dogs with arrhythmias had shock at presentation. So again, would not be surprising to me that there is a correlation there, and I'll talk about in the discussion why I think there is a correlation there. Again, it didn't reach statistical significance, probably a consequence of sample size, but clearly there seems to be a correlation there. These dogs did have a longer hospitalization time, so there was a correlation there with the presence of an arrhythmia and having a longer hospitalization. So in terms of discussion, again, biggest highlight for me, higher rate of benign tumors, almost 40%, much higher than what some of these other previous studies were saying. And this is a cohort of predominantly old, large breed dogs, which is the exact kind of segment that we would expect to have malignant, really bad tumors, but they were the ones that were having 40% benign. So again, we shouldn't always make that assumption just because they're old and big. There are a couple shortcomings that we think that are in this preoperative staging. Again, only a third of liver nodules that were seen preoperatively ended up being metastatic. There were dogs that had omental lesions that we couldn't see preoperatively. And that one then brings that question in terms of this preoperative staging process that we do we need to change it and say, well, should we have different ultrasounding techniques like using a linear probe to really carefully look for these omental mets, or do we need to be considering preoperative CTs, which granted is more expensive, but would be better at trying to see these smaller lesions? Additionally, so like I said before, all of our dogs with transfusions survived but had longer hospitalization times, which we think is just a result of them being more ill at presentation. Shock index, like I talked about before, the way you calculate shock index is really easy. It's just systolic blood pressure divided by heart rate. And like I said, if that value is greater than 0.9, that is a definition of shock. And this is used in both humans and vet patients, specifically dogs. As you can imagine, cats with their heart rates, this wouldn't work out so well. So this is really a dog calculation. But it's been proven in numerous studies that this is actually accurate and useful and has associations to morbidity and mortality. The median shock index in our group was 1.2, which again is high enough to indicate shock, and it's also very similar to other studies previously. And we were unable to correlate it to needing a transfusion or experiencing an arrhythmia, even though we believe there is a correlation there. And the reason we believe a correlation is because the arrhythmias that we see in these dogs, there's two reasons they happen. One is this increased cardiosympathetic activity through the splenic nerve. So you basically, with all of what's happening in the spleen and then us touching it in surgery, that will send nerve signals back to the heart that can induce those arrhythmias. But additionally, these dogs are anemic, they're shocky, they're hypotensive, and they're not perfusing their heart very well. And so all that hypoxia and therefore ischemia to the heart will also contribute to their arrhythmia, which is why we believe that the correlation of an elevated shock index is actually correlated to the arrhythmia, because that just makes sense. And like I said, it's just likely a sample size issue that we didn't prove full-on statistical significance. And then previous reports said that dogs post-op hemoabdomens with arrhythmias have a 15% mortality rate. None died in our study. Exactly why, it's hard to say. Were we just better at correcting hypovolemia, hyperperfusion? But they did have a longer hospitalization time, and we think that that's just because the clinicians had a preference to monitor them for longer to make sure that their ECGs had corrected before they were discharged. So in really the big points that we want people to take home from this study is we want people to decouple the poor long-term outcomes. We understand dogs with hemangiosarc, long-term outcome still isn't great for them, but we want that to be decoupled from the perioperative period, because we do know that perioperatively there is a good chance that they're going to have benign disease that is fully cured with surgery, 40% almost. And that for the dogs that do get hemangiosarcoma, there is a massive amount of research happening right now in how to better improve long-term outcomes for these dogs. So if people have a dog with hemangiosarc, we should be encouraging them to get into these trials, because that's what's going to get these dogs better. So in terms of the limitations, this study only had stage 1 HSA. So stage 1 is presence of this study did not include stage 1 HSA. And stage 1 is splenic tumors with no hemoab. Stage 2 is splenic tumor with a hemoab. And stage 3 is the evidence of distant metastasis. So we had actually done a pilot study where we included dogs with non-ruptured splenic masses, and they all kept being benign, and we weren't getting any hemangiosarcs. And so we made it a requirement that there had to be a hemoabdomen present for them to be enrolled, and that's how we started getting more hemangiosarcs. And so we do believe there's a correlation between hemangiosarc and the actual rupture of splenic tumors, and that's not just us. There's been other studies that have shown that as well. But because we didn't include stage 1 HSAs, it could confound our results a little bit. Like I said before, we did have a slightly small sample size, and it's possible that we didn't capture every hemoperitoneum in our study. Granted, everyone that presents to the hospital isn't going to enroll. So again, even though this wasn't retrospective, we still have the potential to have missed some dogs, and so the numbers that we report could be off by a little bit. So in conclusion, overall, we do have a pretty favorable perioperative outcome for these dogs with hemoperitoneum. There was a higher prevalence for the benign tumors than we thought. There clearly is going to still need to be progress for the dogs that do have hemangiosarcoma, but the goal is that with the work that we're doing and other groups are doing in hemangiosarcoma, we're going to see a similar transformation to that of childhood leukemia. And so these are ALL and AML, acute lymphoblastic leukemia. These are two different childhood leukemias that you see in humans. So when these cancers first came out or first were discovered, it was almost guaranteed that these children are going to die. There was very low survival in these in the 5-year rates. And so what they did is there was this massive amounts of research, numerous groups, lots of collaboration, everyone working together. And over a pretty short period of time, there were these dramatic increases in survivability. And so there's no reason that we can't use this as a model in hemangiosarcoma, and we can achieve the same thing in hemangiosarcoma. And so that's what we're trying to do, and that's what other groups like us are also trying to do. So I think we're just about at time. I only have like 2 slides left just to give you a little bit of an idea of what we're doing in our future studies with this. And so with this group that I just told you about, like I said, this is paper 105. A couple of the future papers are going to be looking at what we call cell-free tumor DNA. And so tumors, they grow very close to vasculature. Hemangiosarcoma is literally part of the vasculature. But what they do is they shed these little kind of pieces of their cells, or sometimes the cells break open and they just release the contents of their cells into circulation, straight into the blood. And what that means is there's this free circulating tumor DNA that came from the tumor cell that is different than the animal's normal DNA. And we have ways to actually detect this, and we can tell what DNA is from a tumor and what DNA is normal. So we can actually tell that. And so what we can do is if we can measure this, we can use this to make a diagnosis. So if you have a hemoabdomen come into your hospital and you do an abdominocentesis and you pull that blood out of the abdomen, we will be able to now take that blood, put it into a test, and say, is this benign or malignant? And that is proven by what we've done. We know that we can do that. And we have a collaborative partner that we're working on that is developing an in-hospital machine that can do this in under an hour. So, in the time that it would take you before you can even get this dog ready for surgery, you can know if this dog has a benign or benign lesion or is hemangiosarcoma. In addition to that, we can quantify the levels of this tumor DNA. So we can correlate that to how burdensome is the disease. So is there metastasis all over the place where it's going to be a higher level of DNA, or is it going to be just a single solitary tumor that hasn't metastasized yet, in which case this number is going to be lower? And then even beyond that, we can then track response to treatment. So will these numbers go down with treatment? As they're in treatment, will the numbers start coming up again once they start developing metastasis? So there's numerous sort of uses that we can do for the cell-free tumor DNA, and really hot area of research in both humans and veterinary world. Another thing we're doing is we're doing genomic profiling of the tumors. And so this is what a genomic profile here looks like. Each of these rows going down is a different patient, and each of the columns going up and down is a different genetic marker for cancer. Boxes that are blue tells us that there's no mutation in there, and that's a normal genetic area, that there's nothing that's causing cancer. Red boxes are ones where we detected a mutation that caused cancer. And as you can tell where this arrow is pointing, there are these kind of areas where you notice that a lot of these patients are having shared that are leading to cancer. So when you kind of pick these ones out and you smush them all together, which is what's over here on the right, we can now get, 1, 2, 3, 4, just maybe like 10 to 12 genes here that we now know these are the most common mutated genes in dogs with hemangiosarcoma. And so that's what we did in our study, is that we found all of the different combinations of mutations, because that's the one frustrating thing about cancer, is that all cancer is caused by a genetic mutation. However, most cancers in any one person is caused by multiple. So if you have hemangiosarcoma, it's likely you have multiple of these mutations, not just one of them. And so the reason that we're trying to find out what all of them are is that we can create drug targets that are going to work better with drugs that will make better long-term outcomes. So right now, standard of therapy is doxorubicin, and that's it. And those dogs only live for 3 to 6 months, maybe 9 months with doxorubicin alone. And that's because we know that is only targeting one of these mutations. We have all of these other ones we could be dealing with. And so what we're getting ready to do is another trial, which is looking at all of these different mutations in here. So PIK3CA is actually the full name. JAK inhibitors, which some of us might recognize the name of with Apoquel. All of these are different mutations, and all of these are different drugs that are going to target these mutations. And so if we add these drugs on in addition to doxorubicin chemotherapy, will we start seeing better long-term outcomes? And so that's what we've kind of gotten to the stage of the point where we're at right now. And what we're about to do is launch our next trial, which is called the Ethos Precision Medicine Umbrella Study for hemangiosarcoma, which is abbreviates to EPUSH. And so what precision medicine is doing exactly what I just described here, where we profile that specific patient's tumor, we find out what mutations that specific patient has for their specific hemangiosarcoma, and then we tailor a chemo plan that is very specific to their tumor. So we know the 5 genetic mutations they have, we know the 5 cancer drugs that are going to work the best for it. An umbrella study means that we're going to investigate multiple drugs for one cancer. So we have about 5 or 6 novel drugs, all being adapted from human medicine, that we're going to, some in combo with doxorubicin, some alone, but we're going to investigate all of those in this umbrella study approach. And this is going to be a 400-dog study. So we're going from 40 dogs to 400, much more valid results, and we'll hopefully be able to get to our goal, which is to come up with a cure for hemangiosarcoma. So with that, I think I went a couple minutes over, but thank you for everyone for joining. Hopefully this was informative and interesting for everyone. Like I said before, this will continue to be a monthly meeting, first Wednesday of every month at 5, so please continue to join. And I will stick around for questions, but thank you again for being here, and I look forward to seeing everyone for next month.